Hi. Welcome to the Go to Room podcast with your hosts, Sophia Garcia and Taskin and Sophia. Tune in as we interview those affected by childhood cancer, gather their perspectives, and help others find comfort in their expertise.
Today we'll be discussing dealing with a diagnosis from a doctor's perspective.
So before we interview the doctor, we just wanted to go over our expectations of how we thought that doctors think that cancer patients should deal with their diagnosis.
So I believe that doctors should not sugarcoat the diagnosis to their patients, especially toddlers, because it's important for their trust to develop a healthy relationship between each other and move forward in the necessary treatments needed to be taken. I also believe that there should be, however, some sort of boundary within this relationship, but the patient should not hesitate to reach out to their doctor if they need further help even after the treatment.
Yeah, I agree. I definitely think that the doctor shouldn't sugarcoat it, but I think that maybe if it's a very young child, doctors may sugarcoat it, or maybe the parents will prefer that doctors will sugarcoat it, or maybe ask to not have their kids be told, which obviously that's not ideal, but I think there's a lot of stigma around cancer, like how we discussed in the past. Like a lot of people don't know about cancer, especially young children. So if it's a very young toddler, like maybe 3 or 4 years old, I'd be wondering if maybe some parents will just ask to not have their kids be told. And maybe some doctors won't agree with this, but I'm not sure how they'll go about that. And I also think that doctors would tell their patients to seek out therapy options, maybe within the hospital, but also with what we've seen with our past interview with Michelle, it seemed like there wasn't a lot of options out there. So I'm not sure how that would work exactly. And I also just think that doctors would just suggest that patients talk to family members and also them about it. Obviously there has to be some boundaries within the doctor-patient relationship, but I feel like some doctors at least would want to talk with their patients about it just so that they'll better understand it. So we wanted to discuss this topic because one of the main goals of our podcast is to help cancer patients and their families to find comfort in the expertise of professionals. So we thought that getting a doctor's perspective would be crucial to this.
We thought that it'd be important to understand how to deal with a diagnosis with an actual doctor and compare and contrast it to the perspectives of actual cancer patients.
So welcome to the Go to Room podcast. Today, joining us, we have Dr. Fox. So Dr. Fox, would you like to introduce yourself and tell us a bit about your career before we get started?
Yes, thanks so much. Hi, I'm Beth Fox. I'm a pediatric oncologist, and I'm currently working as the Senior Vice President for Clinical Trials Administration at the St. Jude Children's Research Hospital in Memphis, Tennessee. I've been a cancer doctor for children for over 25 years and have really enjoyed this as a career. And most of the enjoyment comes from the interaction with the families and the patients, not because telling anyone they have cancer is a great thing to do, but because of the relationships that you can build and the differences that you can make in children with cancer.
That's awesome because we're going to be discussing the relationship between a doctor and the cancer patients. So our first question is, do you think that there's a specific way of delivering the news of the diagnosis of cancer to cancer patients or family members that would be the best way, in your opinion?
So there's no single way to tell a patient and a family that a child has cancer. There are factors that you have to consider and that impact how you discuss the diagnosis. And those include things like the symptoms the child may be having or not having, the age of the child, the type of the cancer that the child has, and the family structure and support system, as well as the family's prior experience with cancer. It's important to be complete and concise and pause frequently. You have to actively listen when you're telling someone a diagnosis like this. This is often an initial conversation in a relationship that's going to require a lot of trust. So you have to recognize that once you say the word cancer, many people don't hear anything else you say on that first conversation. And so You have to be aware of that and come back and repeat things or rephrase them in different ways at different times so that everyone can understand what you're thinking and what your recommendations for the child are. With respect to families' wish, you have to respect the family's wishes, but trust is really important. So the trust has to exist between the child and the physician, as well as between the parents and the physician. And so you have to have an age-appropriate discussion with the child or adolescent in order to begin to build that trusting relationship.
So do you believe that a certain age would affect how you deliver the message? What would be the contrast between delivering the message to a teenager with cancer in contrast to, let's say, maybe a toddler who has cancer?
Great question. So I think it's really important that, especially for teenagers, that they are part of the conversation. I will respect the family's wishes if they if parents or caretakers want to hear the diagnosis initially before we talk to the patient, the child, the adolescent. But I like that to happen very closely together because especially teenagers and young adults, they understand what's happening. And if you don't build that relationship of trust and that you are telling them everything, they will begin to mistrust you and wonder if you're ever telling them the truth. In terms of toddlers with cancer, toddlers approach the world very differently than older children and adults, for sure. And they see the world as, how does this impact me at this moment? And so the word cancer may not mean anything to a toddler, probably doesn't. And therefore, it's more about making sure the a toddler feels safe in the environment in which they're going to be cared for.
So do you have any advice as to how to move forward from diagnosis of cancer?
So the diagnosis of cancer is the beginning of a very long journey. Some types of childhood cancer are very curable. Over 80% of the children who are diagnosed with cancer are cured. However, that's not all children. So how to move forward is, in the early stages, the first days and weeks after diagnosis, there's often a lot to do. There's new treatments, there's discussions, there's planning. And so it's a very busy time. Everything is new and changing very quickly, both for the family and the patient. And you have to take that into account. And often there's a large care team that helps the family to get accustomed to what's happening. Within a month or so, most families adapt to the routine of the doctor's appointments and the inpatient stays and what the cancer treatment means. But it never gets routine. There are always challenges along the way. And in order to treat cancer in children, we often employ different types of therapies like chemotherapy and surgery and radiation. So just when a family feels like they understand the cadence of the chemotherapy, the drugs that we're administering to their child, it's time for something new in the therapy, a surgery or radiation, and everything becomes unknown again. I would say that one of the most important things for patients and families to remember is that it's really, really important to ask questions and establish a support system that you can rely on to help you in your decision making.
So you mentioned a care team that helped the patients and their families throughout the process. Would you say this care team is similar to therapy professionals, or what is the care team really?
So the care team is generally a broad range of different healthcare professionals and other people who are engaged with the child and the family to help them manage not only the therapy, but also the changes in their lives that happen. So there is generally what's called the attending physician, or the doctor who is primarily charged with the overall care for the patient with cancer, the child or adolescent. And that doctor may have other doctors who work with them in shared care. There's also generally a team of nurses. There's a team of child therapists who are involved in the play therapy and other ways to help acclimate the child to their surroundings. In addition, there's often social workers who help not only with the logistics of what's happening for care, but also some of the financial and other strains that come with having a long-term diagnosis. And sometimes there are psychologists, child psychologists in this case, who really help understand the child's needs. And as we do this, there's often many different types of doctors who are involved, and other healthcare professionals like physical therapists, occupational therapists, dietitians, really trying our very hardest to make sure we're covering all of the aspects of getting a child well.
Are there any physical changes that you tell your patients that they should probably expect after the diagnosis of cancer?
So there are many physical changes. I think one of the physical changes that is most difficult for families is the loss of hair, or what we call alopecia. And the reason that this is difficult is because it's such an outward manifestation of what's happening to the child. Everyone can see this. What happens when you lose your hair? People assume that you are being treated for cancer. So that is a very difficult thing for families and some children and adolescents to accommodate to. And oftentimes we'll have the play therapist talk to children about that. It's important to know that's not a painful thing, and it's temporary. And when the therapy is over, most children's hair will come back. I think it's also the thing that, when we talked in the beginning about talking to children and adolescents about having cancer, those children in the beyond toddler, but in the young children, 6, 7, 8, 9, 10-year-olds, they're going to be coming to an area of the hospital where children with cancer are treated. Most of those children will not have hair, and they need to understand that. They need to know how they fit in, which is why I think it's really important that the children understand in an age-appropriate way what their diagnosis is. The other part of being treated for cancer is the many different drugs and treatments that we use, some of which have temporary side effects, like being tired or loss of appetite and weight loss. Others have very long-term effects that actually are not reversible, meaning when the therapy stops, it may not come back. So it's very important that we not only monitor for those side effects, but we are very clear with patients and families what they are and how we're going to help them through those. Those are side effects like hearing loss or potential heart damage that we need to be very careful about. It's really important in my mind to share the usual course of therapy and what is expected for outcome when you talk to patients and families. And I tell them that if we encounter a side effect or the response to therapy that I don't think is expected, that we have to sit down and talk about that, and we may need to change the course of therapy.
Do you believe that these physical changes also have an impact on the mental stability or health of these patients?
Certainly. I mean, when you think about what happens when you have anyone, a child or an adult, has a diagnosis of cancer, your world changes pretty quickly. The things that you thought about your next couple of days, weeks, months, and years have just been changed by all of the things that you're going to have to do to focus on treating that cancer and getting better. Yes, it takes an emotional strain and toll not only on the child, but also on the family around them. And it's important to acknowledge those changes and ask questions about how people are feeling, and be watchful and listen actively to things that they may not directly tell you, but things that you need to follow up with additional questions like, are you feeling sad today? What's making you happy right now? Are there things that we could do to help you feel more, happier? These are important questions to ask every time you interact with a child with cancer.
So, how do you believe patients should maintain a healthy physical and mental lifestyle after diagnosis?
So, I think it's very difficult to say there's only one way to do that. But if a healthy lifestyle means listening to your body, eating nutritious food, and being physically active so that you can be mentally strong, I think it's really important to support that. Good sleeping habits, reasonable eating habits. One of the things that when you treat children with cancer, I think we all know our parents see food as something they can do to help us. And it's really important that we support a child's nutrition, both from the medical standpoint as well as the importance of what it means to take part in family meals. Without making that become a battle between, especially those children in the early preteen years, when if they don't want to eat, they are simply not going to eat. And so sometimes we have to be very careful about trying to find ways to help stimulate their appetite and to make eating part of what they do every day, and to support their nutrition in other ways as well.
What would you say is your least favorite and favorite part of your profession?
So my favorite part of being a pediatric oncologist is partnering with families and the medical team to make a difference in the lives of children with cancer. You may know that there are about 16,000 children each year diagnosed with cancer in the United States. Compare that to 135,000 adults each year who are diagnosed with lung cancer. Childhood cancer is a very rare disease, and therefore having the expertise to talk to families about it is important. I enjoy the fact that each patient is unique, and the patient becomes my highest priority during the interaction. But it's actually through the clinical trials, which we learn from groups of children who are treated in similar ways, how we can make therapy better for all children. One of the frustrations is that we don't have cures for some cancers. And many of the treatments that we use to cure cancer in children have very long and significant health risks for those, including problems with weight, problems with their heart, problems with fatigue and fragility. And these are important things to take into consideration. Even for those children who are cured with cancer, they become lifelong problems. I'm also disappointed that there are disparities in healthcare. Today we're recording this podcast on January 17th, 2022. It's Martin Luther King Jr. Day. It's a day of service. I live here in Memphis, Tennessee, the place where Dr. King was assassinated on April 4th in 1968. And I work for St. Jude Children's Research Hospital, which was established in 1962 as one of the first integrated hospitals for children in the South. It was established to treat all children, regardless of race, religion, or the ability to pay. And we strive, and I personally strive, to try to eliminate disparities in health and in healthcare for all children.
Do you believe that this frustration from knowing that there's no cure as of now for children with cancer, do you believe it takes a mental toll upon people that are in the same profession as you?
So 80% of children who are diagnosed with cancer today will survive and will go on to become adults. It's the 20% of children who we do not yet have cures for that we continue every day to try to find new therapies. I think it is really important that we continue to do that. Does it affect you personally? Of course it does. And you begin to understand how fragile life is and how fragile relationships are. And I personally try to make decisions that allow me to live without regret as we move forward.
You mentioned how you try to make each patient your priority. So do you think this becomes difficult with the amount of patients that you see?
It can be difficult in a very busy practice. And I would say that it is important that when you're in a room engaged with a patient, that first of all, you go into that room, whether it's the initial conversation about the diagnosis or a weekly visit or telling them the results of the scans or tests that they just had, that you are prepared for that conversation, you know the details, and that you focus solely on that patient when you're in the room. The time that you're in the room interacting with the patient is never as long as you would like it to be. There are always more questions. but it's important that the family feels engaged with you and that they have your full attention when you're there, and that you can also bring in all of the other parts of the care team to help you and help the family to ask more questions and circle back with that family as needed, either later in the day or via phone call.
Do you think that frequently diagnosing children with cancer has affected you personally in any ways?
I think that it has affected me in that you understand how quickly life can change, and that life is inherently not fair, right? That unlike adult cancers that sometimes occur because of lifestyle choices, childhood cancer doesn't occur because of exposures or lifestyle choices. It is often a random thing that happens, and you have to adjust to that and support families around that, and personally have a healthy lifestyle, like we talked about before. Get enough sleep, eat well, and certainly get enough exercise that you can come back each day with enough energy to be able to give part of yourself to each patient during each interaction.
We've talked a lot about relationships and building relationships with patients and the doctors. Do you believe there's a boundary between a certain boundary that has to be set when creating this type of relationship?
Yes, I do. I mean, the doctor-patient relationship, it's critical in the care of infants, children, and adolescents with cancer. And it's a relationship not only with the patient, but it's also, you have a distinct relationship with the parent or caretaker. And this relationship, it's based on mutual trust. And this requires objectivity. So yes, there have to be boundaries. You may need to tell the patient or their parents and caretakers very difficult news, and it requires empathy without pity. You have to help guide them in the decisions that are appropriate to their values, and those values may differ from your own and their clinical situation. So I believe those boundaries are important in understanding that you will be giving advice to people and guiding the care of one of their most precious things, their children.
So we've talked about the patient-to-doctor relationships, but do you think that patient-to-patient relationships and connections are something that is possible and that could be helpful for patients?
Yes, I believe that patients understanding that they're not alone, especially adolescents and young children, being able to interact in appropriate ways, share what they feel is appropriate to sharing from their perspective is important. Those relationships, I think, can be opportunities for those relationships can be provided for in a safe way in the hospital, but they can't be required. We value patients' privacy, and doctors don't talk to other patients about what's going on with patients. And it's not uncommon in a pediatric oncology practice for a child to come in for their appointment and say, I saw a patient in the waiting room who had this. And you have to know that they probably did see that, and you just have to ask them how that made them feel. But you can't tell them what you know about other patients because you have to have that trust that you will trust what they have told you as confidential, and other patients have done the same.
From our previous research, we've come to realize that some patients, they develop this sense of anxiety of not having constant communication with the medical team. Do you feel like that's something that is common? And if it is common, are there any ways to resolve that problem?
So I think it's very important that there are ways that patients know clearly how to reach out to their care teams at any time of the day or night for important medical questions and concerns that they have. And those systems have to be set up in such a way that are available to the patient, but also allow the physician to, if they're in a room with another patient or at home at night, that we often cover for one another physicians, so that other physicians who also know the patients can answer those calls to be available to patients.
Well, thank you so much for joining us today. Before you go, is there anything you want to share about your career or your mission or anything?
I would like to thank you for what you're doing to help with awareness for childhood cancer. I think it's critically important. Your perspectives are vitally important to understanding how children and adolescents think and feel, and putting people together for these conversations is fantastic. I will say that childhood cancer is an important part of my career and my life, and that it is important that we all work together to make sure that we're providing children and adolescents the care that they need and the new therapies that they need. So I appreciate that you're thinking about not only the care and that you're thinking about the care in a way that's beyond just the treatments, but care for the patient as a whole, so that people can grow up to the best people that they possibly can, even if they've had cancer as children.
Thank you so much for your insight.
Well, thank you both.
Thank you. Bye.
Bye.
Have a nice day.
So I feel like it's important that we just debrief like what we heard from Dr. Fox, and like compare it to our own perspectives, and also maybe what other people would expect, just so people can have like a better understanding of it and things like that.
So, I thought that there were some similarities between what we thought before hearing from Dr. One and what we think after the interview. So one similarity I realized was the idea of building this trust with the patient and patient family, and how vital it is during this hard time. After the interview, I've come to realize that it's a bit different from telling a teenager they have cancer versus a toddler with cancer. I didn't really focus on that a lot, that the different age groups within children itself like plays a part in how you would deliver the news. But regardless, it's still important to be truthful to both age groups and know that communication is key in order to provide the comfort they want during their path of cancer. I also found the idea that Dr. Fox mentioning about losing hair being an emotionally challenging side effect important, because it serves as a visible symbol of the patient having cancer.
Yeah, and just to add on to that, like with what we've heard with Michelle in the past, like with how she was bullied when people found out she had cancer, because it's just a lot of people don't know what it is. The like visible symbols, like how you mentioned of a patient having cancer, like that's going to be so crucial, especially hair loss. I think that's such a big thing that has a lot of stigma around it, because when you're young, like everyone has like, I think, I don't know, hair is an important part. Like it's just a defining feature. So if you don't have that, a lot of people are going to question it, and maybe because they don't know what it is, they're going to be judgmental about it. I think that's like a big thing where people don't know a lot about a subject, and because of that, they'll tend to judge others for it or bully others for it, and that's why like a visible symbol is like such a big part of that. And also what you said about age groups. I also, we didn't ask this, but I was like, I'm like, do you think there are like different doctors for different age groups? Because how you tell like a toddler or something that they have cancer is going to be very different than like telling a teen. And also, I'm pretty sure some doctors work with like some pediatric oncologists work with like 18-year-olds and young adults. So I wonder like if there's different doctors for different age groups. So.
I personally don't know if there are doctors that like I don't know, like that specialize in specific different age groups within like what we call like children. But I do think it might be beneficial, because like you said, it's different from telling a toddler that they have cancer compared to like telling a teenager they have cancer. And I feel like it takes like, I think, different skills. I'm not like particularly sure like what type of different skills, but it takes like different skills in telling like a toddler that, oh, you have cancer. But like just like Dr. Fox said, the word cancer doesn't really register to their minds. It's more like you want to be able to understand them and know like what they find comfort in, so then they'll be able to continue their like daily routine of like just doing like whatever toddlers do. But regardless, like it's still important to like know that you have to like tell them what's going on with them, even if it's like watered down a little, maybe like just to like help them understand it. Like just to make sure that like you build that trust with them.
And based off like what Dr. Fox said, like what you're saying, like it's different like between like each different age group. I feel like based off what she knows and how she because she seems very knowledgeable on this subject of how to tell them. It's obviously like her experience over time, but I think possibly maybe there's like training for different age groups like that the pediatric oncologists have to do because she knows a lot about how to explain a cancer diagnosis to the families and children, especially different age groups, and how to approach it. And she seems to value like the parents' perspectives and how they want to tell their child and things like that. So I think there's definitely probably some training or something. And also, like based off my just expectations, like I didn't really expect there to be a lot of help within a hospital, but based off what Dr. Fox said, like there was a whole care team within her hospital, and it had like child therapists and psychologists, which I would have expected in a care team. But then there was also social workers and dietitians, and I feel like I didn't expect social workers, especially because I feel like the financial burden of cancer isn't talked about like that much, even though that's such a huge part of it. And especially like we talked about in the episode about the psychological impacts, the financial strains are going to take a toll on the child as well because they're going to know that that's affecting their parents. So I think a social worker working with the parents in the hospital, especially because some parents may not want to seek social workers outside because it can be an extra expense. So I think that having that within the hospital is really crucial, and I just didn't expect that to be something that would be there.
I think that's like the difference between our expectations. I like I did think that there were like other like social workers and like a whole care team within the hospital because I feel like that's like crucial and beneficial and like it's like something necessary to have. But what I feel that like with Michelle, for example, it didn't really help her. Like she didn't have this care team that Dr. Fox was talking about, and so maybe we can like say how like these care teams. It depends on like the patient itself. It might help for some patients, but it might not help for other patients. It always depends on like who the patient is and how they want to seek comfort in. So I guess like having these different various care teams and people within the care team itself is beneficial because then it provides this range of like resources that you can use to help based on like the different ways you can comfort someone.
Yeah. And also I think it's different because Michelle said that she didn't feel like she got a lot of help within her hospital, but it could also be because I'm pretty sure she's located in the Canada or Ontario area, and we're obviously in the US, so it's also something to think about. It's gonna like depend like for different regions, especially in like low income regions where there's not that much like medical help or medical assistance that's accessible to everyone. That will definitely affect like if they have social workers and therapists in their hospital, because many people may only see the physical side of it as most important and treating that part as like the most crucial, especially if they are in a very tight like financial situation.
Yeah, I'm glad that you brought that up. Honestly, the income disparity and like not even income disparity, like racial disparity within these communities. Maybe that's like a good question we can ask future doctors because a lot of times we don't like. Oftentimes we gather the perspectives, like it's just a general idea, but it's also crucial to understand that like these low income communities often do not have the same resources that like other hospitals may have in like higher income communities. Mm-hmm. And so it's important to like be able to like establish like I guess like enough resources for like both communities because like they're both going through a lot of stuff, and it's like it's important to have these resources at hand for even like low people from low income communities.
And in terms of like just comparing and contrasting maybe the cancer patient's perspective, like Michelle's perspective versus the doctor's perspective, in terms of like what they were saying or how Michelle said that when she first heard about her diagnosis, like she was in disbelief. I feel like that's why it's really important of the way that Dr. Fox was talking about how she delivered the news to her patients, how she's very like concise and patient, and she takes pauses and lets them ask questions. And I think that maybe if that experience is applied to more cancer patients, and like when they're being told about their diagnosis, it'll change their entire experience and how they view cancer, because obviously it's a very not a positive thing, but if they are, it's treated in like a positive light where there is help and they can ask questions. I think that'll definitely help make their journey a little more supported, like they'll be more supported, and that'll like change the entire journey.
I agree with that. Like how you said, Michelle, she was like in complete disbelief when she heard that she has cancer. So like those 3 words are really dangerous, and like how powerful they have like a powerful impact on these patients. Mm-hmm. So like how Dr. Fox said, once someone hears that like they have cancer, they don't listen to anything else after that. So one thing that I liked that she said during the interview was like how it's important to have like a nice timing when talking about these type of stuff, because you don't want to just blurt it out all of a sudden and like have like no comfort available or nothing like that, and just go right into it. Like you want to be able to make sure that they feel that it's comfortable enough to ask questions, and you want to be able to like explain how to move forward from this cancer diagnosis, not just like make them hear about it and then like freak out about it. I think like timing is such an important key in this diagnosis of cancer. And I think Michelle talked about that a lot, like how like hearing that she has cancer, you won't listen to anything else the doctor has to say. And so it's important to have like precise timing and like how to move forward with the cancer.
Mm-hmm. And that's also really important if there is a lack of like access to like therapy options. Like in her hospital, like Michelle didn't have a lot of or at least a lot of helpful access to therapy. So I feel like the way the doctor says it is very important, because if that's like all the support you have within a hospital, that's going to be really crucial.
If you or someone you know are looking to support childhood cancer patients and help them to experience a better childhood but are stuck on how, Cancer Kids First may be the answer for you. Cancer Kids First is a nonprofit organization started by the high school Olivia Zhang that aims to improve the childhoods of cancer patients. Through volunteer work, donations, fundraising, and the creation of this podcast, those working with Cancer Kids First work to further its mission.
If you're interested, go to www.cancerkidsfirst.org/get-involved to get involved. Another way to support the mission of Cancer Kids First is to listen to this podcast and follow us on Instagram and TikTok at The Golden Rim Podcast, and on Twitter at TGR_on-air. You can also get in touch with us through our email, thegoldenrimpodcast@gmail.com. Episodes will be airing 2 times a month. So before we end this episode off, we want to give our Sunday trivia shoutouts. Every other Sunday, we host trivia on our Instagram stories, and participants that get 3 or more questions right will get shoutouts in our podcast episodes. To play and possibly get a shoutout in our next episode, make sure to check out our Instagram at The Golden Rim Podcast every other Sunday. So these are the shoutouts, and if I butcher some of the names, I apologize. Okay, so we have at Mia_Morales, at Sapna Dance 1, and at Fighting_for_Felix.
And we have at I Am a Griefist, at Lexi Kali, at G.Grayson.
We also have at warrior.princess.jillian, at K_Mater, and at Grace Hartig.
Thank you so much for joining us on our episode of the Golden Room Podcast. If you have any ideas for or want to be involved with for future episodes, make sure to check out the link in our Instagram bio. Have a nice day, and we'll see you in the next episode.
Bye.
Bye.